Got. That's good. So whenever we are starting to read the ECG, after checking the particulars like name, age, gender, we are going to check the rhythm of the ECG. Okay. So there are two things that I highlighted here. You have to check whether the ECG has a regular rhythm or irregular rhythm. Second thing you have to notice is that whether it's a sinus rhythm or it is a non-sinus rhythm. Okay. So what is a regular ECG and what is an irregular ECG? Um, does any of you knows about it? Okay. So I'll tell you what is a regular ECG. If the number of boxes are equal in between these two R waves. For example, like here we are having 1, 2, 3, and 4 boxes, right? So again, the distance between R seems to be equal to me. 1, 2, 3, 4. Okay. And then 1, 2, 3, almost 4. So, and this means that there is equal time between the heartbeat, or you can say ventricular depolarization. And it seems to be at a equal distance. All of the RR waves seems to be at an equal distance. So we will say that it is a regular rhythm. But if you see that the distance between this R and this R, for example, this R to this R, the distance seems to be pretty much longer as compared to this R and this R. So this type of rhythm is called as irregular rhythm. Okay. So now you know the difference between regular and irregular. So basically what do? We count the boxes between the RR and we see whether the distance is equal or not. If it's unequal, then it's irregular. If it's equal, then we call it a regular rhythm. Second thing, what we have to check is whether is it sinus rhythm or non-sinus rhythm. So what is a sinus rhythm? We call sinus rhythm if we find P wave before every QRS complex. Okay. So if you are seeing this is a P wave, right? P wave before every QRS complex. So here it's a P wave. Then I've got a P wave here before QRS. Then again we have P before QRS. Then we are going to say that it is a normal sinus rhythm. Okay. And second thing, P upright in lead 2. So what does that mean? Upright means that it is a positive deflection. Positive deflection means anything coming positive. Okay? Coming above the isoelectric line. So this line that you can see on which this ECG is running will be called as an isoelectric line. And any line going above that isoelectric line will be called as a positive deflection or upright. And like this, S wave is going below the isoelectric line, so it is called as a negative deflection, right? So P has to be upright and lead 2, or we can call it a long lead. So what is a long lead? Long lead is a lead. Basically, it is given at the end of the ECG, and it is given like in a very detailed manner. So you can read and interpret your findings in a very better way rather than comparing it with the shorter intervals that are mentioning for other leads. Okay. Now we come to sinus arrhythmia. How do you, what do we call, why are we calling this sinus arrhythmia? Because as I already mentioned that rhythm is irregular, but P wave is there. Okay. You can see that there is P wave before every QRS complex. Then again, this will be called as sinus arrhythmia. Arrhythmia, that it is having irregular rhythm. Sinus, why we are calling it sinus? Because we can see P wave before every QRS complex. Okay. So in what conditions we are going to get this sinus arrhythmia? So sinus arrhythmia is basically like a physiological phenomena that is happening when we are having respiration, the normal respiration. The child is normally, when he is breathing in, so the what happens, the heart beats faster in inhalation. And you can memorize is like that. For example, when we are exhaling, like we are taking the air out of the lungs. So what are we doing? We are just relaxing, right? So the heart also relaxes. And this is basically because of the vagus nerve. Vagus nerve acts as brakes, the brakes we have in car. So what does it do? It stops the car, right? So vagus nerve also acts like brakes for the heart, and the vagal tone increases while we expire. So that's why this distance increases, and the heart also relaxes when the child is breathing out. So sinus arrhythmia is a normal phenomena. Okay, so you should not get worried because of this. Okay, so I hope this rhythm part is clear, because in the coming scenarios I'll be asking you to see for the rhythm whether it's regular or irregular, and I want you to contribute, because ECG without contribution will not be a fun thing. Okay, so coming to the next slide. So now we come to the rate. Okay, so here we are calculating the heart rate. So first we see the particulars, second we see the rhythm, whether it's regular or irregular. Now we check the rate. What is the heart rate in the ECG? This is the third thing basically to check. And how do we check it? There are formulas to it, and there is another way to find out. I'll tell you the very easy way and very practical way, and in a very short period of time you can easily guess how much the heart rate is. So for a regular rhythm, this is the formula that you have to calculate the number of big or the large boxes between the RR interval. Like this, okay? So this is R and this is R wave. So you have to calculate the number of boxes, number of large squares. So this is a large square, right? So you'll calculate these and you'll divide it by 300 and you'll get the heart rate. But in case of irregular rhythm, what are you going to do? You have to basically count the R waves in the ECG strip and multiply it by 6. And to tell you what is a 6-second ECG strip, so there are two types of ECG strips. One is a 6-second ECG strip and the other one is a 10-second ECG strip. And how are you going to find out this? So on an ECG paper, ECG graph, if you count the large boxes and if they appear to be 30, the large boxes, if they are 30 in the whole strip, then this is a 6-second strip. Okay. So you're going to count the R waves on a ECG strip and multiply it by 6. And if you find that ECG strip seems to be a little longer and it has got 50 large boxes, then you are going to multiply it with 6. Okay. So it's vice versa. So if you get a 6-second strip, then you are going to multiply it by 10. And if you get a 10-second strip, then you're going to multiply it by 6. Okay. So heart rate, number of R waves in 6 seconds into 10. So you'll multiply it with 10 and you'll get the heart rate in an irregular rhythm strip. We'll do that. We'll do the examples. Then it will be very much clear to you. Now this is that I told you that to calculate the heart rate by just looking at the ECG, and you don't have to use any kind of formulas. So this is the way. So how do you check it? So one large box, we assume it to be 300. If there are two large boxes, then we assume it to be 150. If three, then we assume it 100. And if four, we assume it 75. The fifth one, about 60, and then it drops down. Okay, I want you to memorize till 60 because most commonly you'll get these ECGs which are having the range from 300 to 60 beats per minute, right? So, for example, if I'm looking at this ECG, so I'll count just the boxes. For example, is there one big box? I'll say 300, 150, 175. So I'll tell the senior that, okay, the heart rate of the patient is 75 beats per minute. So personally, this is my favorite, and it is very practical, and you don't have to like calculate each and everything, because as medical students, most of us are very bad in maths. So we don't want to open, cell phone every time. So, but just by looking at it, okay, first big box 300, 150, 100, 75, 60. So, so below 60, it's bradycardia, and above 150, it's tachycardia. And it again depends on the age of the child. So, this is how you calculate the heart rate. But obviously, it is for the regular rhythm only. You cannot calculate heart rate by this method in an irregular rhythm ECG. Okay, so do you want to participate? Can any of you calculate the heart rate for me and tell me about the rhythm? Dr. Hafiza, are you there? Or anyone? Dr. Saira? Okay, you can type in the chat box if you want. Okay, we have a lot of people here. Hmm, anyone? Or maybe you guys are tired after the rosa. Okay, very nice. So I'm getting some answers here. Okay, yes. So it's a regular. Very nice. Dr. Saira, Dr. Muniba, Dr. Hafiza. Very nice. Dr. Babar. Yes, and heart rate appears to be 150. Okay, let's see. Yes, you guys are right. Excellent. So we'll move further because these are very, little things about ECG. Okay, can anybody tell me, suppose it's a 6-second strip, and now tell me about the rhythm and the rate. Hmm. Dr. Shanze, 170 beats per minute. Okay. It's an irregular. Very nice, Dr. Javeria, Dr. Hafiza Javeria. That's a very good answer. It's an irregular rhythm. Very good. And what is the heart rate? How do you calculate the heart rate? I'm telling you that it's a 6-second strip, okay? And you can count the large boxes. There must be 30 here. Okay. So you, hmm. So you can basically what you're going to do is you count the number of R waves. So what are the number of R waves? So we have, so this is I think 1 and 2 and 3, 4, 5, okay, 6, 7, 8, 9, and 10. So you are counting the number of R waves and you're going to multiply it with, okay, we have got new messages. Yes, these are 10 R waves. Dr. Zishan, you're right. Okay. Okay, now we get the heart rate, right? So we have to multiply it with 10 and we got the heart rate. That is fine. So you got the idea of the rate and rhythm. So I don't think it will be a problem for you to guess about the, okay, great. Okay. Now let's go to the next step. Now we go to the axis. Axis is more easier than rate and rhythm. Okay. So for your information, you should know that the normal axis of the heart lies between minus 30 degrees to plus 90 degrees. That is from this part to this part. Okay. And we check the axis in the lead 1 and AVF. So you should memorize this part as well. And in infants, especially in the neonates, the right axis dominance is pretty normal. Okay. So when the baby is born, you know that the right heart is more active than the left heart. So the right predominance is always there. And it slowly and gradually over the period of years, it changes. And the changes are happening. And eventually by 3 or 4 years, and then after, you can say that after 7 years, it looks like more of an adult ECG. But before that, right axis dominance, especially in the neonates, is there. So this is the pie chart. Basically, it's telling you that the normal axis is between the minus 30 and plus 90. And if the and you should know that the current, I told you that it flows from the right side to the left side like this. Okay. So we should know that anything above 90 degrees till 180 degree will be falling in the right axis deviation, and anything between minus 30 and minus 90 will be left axis deviation, and the other is extreme axis deviation. Okay, so how do you find like whenever you see the ECG, how are you going to find out what axis like what is the axis telling you? So basically, it's very easy, very practical. Like by just I mentioned the rate, like how you count the boxes. Like one boxes is 300 and the other one is 150. Just like that, by just looking at it, you assume that lead 1 is your left thumb. So I want all of you to raise your left thumb. Okay, and then lead AVF is your right thumb. If both are above, you can call it above or you can call it up. If both are up, then you will say it is positive. Whenever you are saying thumbs up from both of your thumbs, so it is positive, it is normal axis. If both are leading towards upward direction. Okay. And in the right axis and the left axis, whichever is up, we will dedicate the axis to that side. For example, if somebody, if there is left axis deviation, so lead 1 will be positive. For example, your left thumb is up and the right thumb is negative. So what is this? Left axis deviation, because your left thumb is up, right? And in the same manner, if the lead 1 is negative and lead AVF is positive, so you because your right thumb is up, so you'll say that it is right axis deviation. So it is a very easy thing. I'll give you an example so that it will be more easy to understand. So I want you guys to answer this one. Which axis is present in this ECG? So lead 1 is your left thumb. So this is the lead 1, right? And here we have lead AVF. Okay. So which axis is this? And I told you up means positive deflection, or you can say upright. So this is going up. Okay. The R wave, basically we are looking at the direction of the R wave, right? So this is up. So your left thumb is up. Okay. And then you are having a look at the AVF. Okay. What is happening in the lead AVF? Is it going down the isoelectric line or it is positive on the isoelectric line? So you can see it is again positive. So which axis is this? Okay, I'm going to read some answer. Exactly, exactly. Everybody's right. So it is a normal axis. Easy peasy mac and cheesy. Okay, so everybody got the idea. That's great. Let's move forward. Okay, so which axis is present in this ECG? Just look at the lead one, raise your thumbs, and then decide. I'm not going to help you in this one. Okay, I'm glad that people are replying. Can you show again the pic of angle? Um, okay, so you want to see basically the pie chart that was telling you about the axis, right? So everybody's answering left axis. Okay, first we'll show Dr. Shanze about the slide. This one, are you talking about Dr. Shanze? For a teacher, if the teacher is asking something, so I want you to say yes or no because I am talking to humans, right? Okay, okay. You're most welcome. No problems. Mm. Okay, so here, okay, so lead one is my left thumb. So it is up, very nice. And lead AVF is my right thumb, which is going down. Okay, so again, it's a left axis deviation. Very good. Let's move to the next ECG. Okay, which axis is this one? Right axis. Good. So it's not that difficult. So now you know the particulars about the rate, about the rhythm, first rhythm, sorry, and then rate, and then about the axis. So it's not that difficult. Okay, so previously I told you about the normal axis. Normally you are going to get the normal axis deviation, right? But in case of right ventricular hypertrophy, we are going to get the right axis deviation, and in cases of left ventricular hypertrophy, we are going to get the left axis deviation. And also in the cases of ostium primum, that is ASD of primum type or atrioventricular septal defect, we are going to get the left axis deviation, which we also call as superior axis. And in exams like AKP, they mention you this. And in the last class, I also there was a detailed slide on this that what are the findings that you are going to get on the AVSD, what ECG findings. Okay. So I think people are clear so far. Let's move forward. So basically, these are the waves. I know you all know all of these deflections. I just want you to just recall this one, okay? So basically, the first positive deflection on the ECG graph is the P wave, and it is a positive deflection, and it shows the atrial depolarization. Okay, and then what happens? The electrical impulse, it moves to the AV node. So there is a relay, there is a pause in the electrical impulse, a little pause that I mentioned in the first slide, that how the electrical current is moving down the heart. Okay, so then what happens? The electrical impulse is going through the AV node, and then it's going to the ventricles to depolarize it. The electrical impulse is making ventricles to contract. So we are getting Q. That is the first negative deflection on the ECG. And then the tallest wave is the R wave on the ECG. And then we have a negative deflection again, S wave. And then ventricles are going to repolarize. Okay, so these are the segments and these are the intervals. So what are the difference between segment and interval? Anyone? Superior axis mean both negative. No, superior axis mean it is left axis deviation. Extreme axis mean that both will be negative, like lead 1 and AVF both will be negative. Okay. So the segment is basically, it doesn't have a wave. So it is a distance between, for example, it starts from the end of the P wave till the beginning of the Q wave. So what we call it is a PR segment. But PR interval, it includes the PR segment plus P wave itself. Okay. Same goes with the ST segment and QT interval, because we are calling it interval because it has got Q wave. Dr. Saab, please, your video is on. Just be careful with that, okay? Okay, so these are the segments and all about the intervals. Then we'll move to the first wave of the ECG, that is the P wave. Again, very easy to understand, nothing complex about this wave. So what are we going to do is we are going to look at the width, okay, and about the height, that is the amplitude. That which P wave we call that it is a normal P wave, and which one we will call it is a tall P wave or a wide P wave. So basically the duration will be 0.12 seconds, or we can call as less than 120 milliseconds. So in the first slide, when I was telling you about the calibration, I told you that the first small box is equals to 40 milliseconds. So obviously three small boxes are going to make 120 milliseconds. So the P wave in width, it should be less than three small boxes. That means just memorize that it is almost 2.5 boxes. Okay. So 3 boxes से कम तो आप याद रख लेंगे 2.5 बॉक्स के अराउंड इसकी विड्थ होनी चाहिए, चौड़ाई होनी चाहिए. Okay. And if I talk about the height or the amplitude, it should be around the 2.5 millimeter again. So very easy to memorize. Both should be around 2.5 small boxes, the width also and the height also. So let's look at the P wave. Now look here, one small box, two small box, three small box, and it is slightly protruding in the fourth box. So basically it's a tall P wave, which we also call as P pulmonale. And what does it show? It shows us about the right atrial enlargement. Hmm. Okay. ओके. सो आप इस तरह से भी याद रख सकते हैं कि पल्मोनरी ट्रंक जो कि राइट साइड पे होता है, और राइट साइड से आपका ब्लड जो है डीऑक्सीनेटेड ब्लड, इट गोज टू द लंग्स फॉर ऑक्सीजनेशन, राइट? सो यू कैन ऑलवेज रिमेंबर दैट पी पल्मोनेल. सो पल्मोनरी ट्रंक मोर राइट हार्ट की बात हो रही है, तो इट शोज दैट राइट एट्रिया इज enlarged. Okay, so right atrial enlarged, you will get tall P wave. And then again, P mitral valve is present on the left side. So you can just, for the memorization part, I am just like telling you how to memorize this one. So again, this P wave we call as a bifid P wave, or a P wave which has a notch in it. You can see, okay? इसको bifid भी कहते हैं, notch P wave भी कहते हैं, P mitral भी कहते हैं, and it shows us about the left atrial enlargement. Okay. So there are different congenital heart defects in which we get right atrial enlargement, and in some we get left atrial enlargement. And we discussed some in the last class, I think I gave in the sample lecture. But again, when we will discuss the congenital heart defects, I'm going to repeat these so that you know by the diagnosis as well, in which we get the P pulmonale and in which we get the P mitral. Okay, coming to the PR interval. So what is normal PR interval? It obviously it increases with the age as the child is growing. Okay, but for your understanding, you should know that it should be less than 0.2 seconds. Okay, or you can say 200 milliseconds. Hmm. So now this is the slide that shows you about the short PR interval and the long PR interval. Okay. So here you can see in the first slide I showed you, there was a proper distance from the P wave and the Q wave, but you can see the distance is obliterated here now. There's no distance. Right after ending the P wave, the QRS complex is getting started here. It happens in very common WBW syndrome. We are going to discuss this in detail because it's a very favorite topic of, I think, in Pakistan as well, and in MRCPCH, because this is very common in children. So we are going to discuss each and everything and exam scenarios regarding this as well. Okay. So short PR interval, you should memorize that it happens in WBW. It occurs in other conditions as well, but for the right now, I just want you to memorize this important one. Okay, coming to the long PR interval. So what is a long PR interval? Any PR interval that is greater than 0.2 seconds or 200 milliseconds, we call it as a prolonged PR interval. Here you can see that PR interval is very, very long. From here till here. Okay. Again, it's very long. Okay. So in what conditions we are going to get the long PR interval? This also we are going to discuss in upcoming slides and in very much detail, that you should know that in atrioventricular conduction delays or blocks, you are going to get prolonged PR interval. Prolonged PR से आपको क्या समझ में आता है? हमें ये समझ में आता है that there is a kind of a pause, there's kind of a delay from the SA node to the AV node. Like SA node से AV node तक बात बहुत डिले होकर आ रही है. So ventricles are getting depolarized in a delayed manner. Okay. तो ये हम इसको फर्दर भी डिस्कस करेंगे. एंड इन केसेस ऑफ मायोकार्डाइटिस, अगेन in myocarditis we are going to get prolonged PR interval in rheumatic fever and digitalis toxicity. And another drug overdose, like we can get this, and again in hyperkalemia, we are going to get this. Okay. So let's move to the next slide. So I just mentioned you that in what conditions we are going to get the prolonged PR interval, but you should also know that later we'll discuss the heart blocks, AV blocks as well, but which PR interval is not bothersome and you just have to observe it, you don't have to treat it. So if you're going to get just you are getting prolonged PR interval, but it is preceded by P wave and you are getting QRS, there is no drop beats, like there is ventricles are depolarizing preceding by the P wave, but it's just that PR interval is prolonged, then you are just going to observe that patient. Okay, and there is no need to worry. But if कि वो डिले इतना बड़ा हो गया है that you are getting a drop in the ventricular depolarization. For example, electrical impulse start हुई थी ऐसे नोड से, जैसे बिजली आना स्टार्ट हुई आपकी ऐसे नोड से, एंड इट केम टू द फर्स्ट स्टॉप, उसका बनता था एवी नोड. वो एवी नोड पे आई है, लेकिन एवी नोड पे आने के बाद वो इतनी स्लो हो गई है कि आपकी फर्दर जो सप्लाई थी आगे की तरफ वो ड्रॉप होती जा रही है. So if you're going to get the drops, then you have a red flag, or there's a red alarm, and you're going to like treat that condition, or you're going to like warn yourself, okay, now there's something going wrong with the child. So just having the prolonged PR interval with normal P waves and normal QRS, just don't worry, just observe the patient. But if you are getting drop in the ventricular depolarization or drop in the QRS complex, which will happen in the second degree heart block, then you're going to be more vigilantly monitoring your patient and going to treat that condition. Okay, so it can be physiological as well. Like in the children, when they are sleeping, there's high vagal tone. I told you about the vagus nerve, that it is like a brake to the heart. So it is going to, slow down the heart. So there's kind of a pause and delay in the electrical impulse. So in sleep, it can happen. So just don't worry. In some patients, it is a normal finding as well, other than sleep also. Okay, in few pathologies, like I mentioned earlier in the earlier slide, like rheumatic fever, myocarditis, in some congenital heart defects, you can also get these. And in hyperkalemia and digoxin toxicity, you can also have this prolonged PR interval. Okay, now we come to the first degree heart block. So I just made a poem to memorize this. If R is far from P, then you have a first degree. Okay, so now we are going to discuss the atrioventricular blocks. तो अब हम डिस्कस कर रहे हैं ब्लॉक्स को. देर आर 3 degrees. देर इज फर्स्ट डिग्री, देर आर टू, देर इज अ सेकेंड डिग्री एंड देर इज थर्ड डिग्री. And in second degree, we have two further categories, that is Mobitz type 1 and Mobitz type 2 heart blocks. Okay. So in the first degree, I told you that nothing is happening. It's just that PR interval is prolonged. Okay. So you just have to observe the patient to इसमें परेशानी वाली अभी कोई बात नहीं. We just have to observe and we have to see obviously what are the risk factors in this patient and then manage accordingly. But the heart is doing so far, it's fine. Let's see what happens in the second degree heart block. So you can see that there is prolonged PR interval. See here and then here. और कहीं कहीं पे आपको लग रहा है कि वो मर्ज हो गई है टी के साथ. Okay. Okay, now we come to the second degree heart block. Again, I told you that there are further two categories. It is subdivided into two categories: Mobitz type 1 and Mobitz type 2. Mobitz type 1, we also call it as a Venki bag phenomena. Okay, so Venki bag की poem का क्या है वो आपको याद होना चाहिए. Long, long, long drop, then you have a Venki bog. Okay. So what is happening? There is a progressive long, long, long means that PR interval is getting prolonged than the previous one. Okay. So there is a progressive prolongation of the PR interval until there is a loss of AV conduction. Okay. So what we can see here is that this is a P wave, right? So here is a P wave. It's short and then it is getting long here. PR interval, then you can see it is getting more longer, and then you can see here it is getting more longer until the QRS is there's a drop beat here. You can see there's no QRS here. Okay, so this is what we call second degree heart block, that there's a progressive prolongation of the PR. This comes in exam, so you should know this. Okay, PR interval आपका लंबा 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 होता जा रहा है until there's a drop of the QRS complex. So this is what I was talking about. Then you come to the Mobitz type 2 heart block. अच्छा, Mobitz type 1 पे भी you just need to observe the patient. Okay. But in case of Mobitz type 2, what is happening? It is a normal PR interval, but periodically there is a drop in QRS. So now we are going to get a periodic drop in the QRS. एक पैटर्न आपको समझ में आने लगेगा कि हर 2 P waves के बाद एक QRS ड्रॉप हो रही है या हर 3 P waves के बाद एक QRS आपकी ड्रॉप हो रही है. ओके, मे बी 2:1 आप कह लें या 3:1 आप कह लें. ओके, सो here you can see that it is short. It is PR interval. Obviously, it is prolonged than 0.2 seconds, 200 milliseconds से ज़्यादा है, but it is not getting a prolongation, progressive prolongation नहीं है, like type 1. And until there is a drop beat here. Okay. So here you can see again, PR interval is prolonged. And then PR interval is normal. Sorry, I correct myself. PR interval is normal. And then there is a drop in the QRS. तो इसमें आपको P waves का एक पैटर्न मिलेगा that after every 2 P waves you are going to have a drop in one QRS complex. ये आपको पूरी ECG में आपको दोबारा से जरा अच्छा सा समझाएंगे with the example. Okay, now you have a third degree heart block. So in yes, again in Mobitz type 2, you have to treat the patient. Okay. So according to the condition, why it is happening, then you have to treat either with the temporary transcutaneous or transvenous pacing, whatever. These are the basically the treatment of choice for an emergency. Okay. Whenever we get a slow heart rate caused by AV blocks, so these are the treatment options we have. Okay, now we have a third degree heart block. Third degree heart block is, I think, exam favorite question, and they mention it in a neonate. And I'm going to tell you that what are the conditions that are going to show this third degree AV block. So third degree में क्या हो रहा है? Third degree में there is no atrial depolarization is conducted through the AV node. Okay. So पहले हमारे पास क्या हो रहा था? There was conduction happening, but it was getting delayed and delayed and delayed. Okay. समझ लें कोई भी आपने डिलीवरी की है, लेकिन वो डिलीवरी जो है वो हो तो रही है लेकिन डिले होती जा रही है। पहले 1 में भी 2 में भी इसी तरह हो रहा था, लेकिन अब क्या हो रहा है? देयर इज नो एट्रियल डिपोलराइजेशन इज बीइंग कंडक्टेड थ्रू द एवी नोड. नाउ पी एंड क्यूआरएस हैव इंडिपेंडेंट but regular fixed rate. Okay, so basically they you can understand this that there are two friends and now they are separated. Okay, the atria and the ventricle, they are not talking to each other anymore. ठीक है, जैसे वो क्या आजकल कौन सी देयर इज अ फेमस ब्रेकअप दैट इज वायरल ऑन द इंटरनेट. You can just memorize it with that. Okay, so now they are separated, and both of the parties are not talking to each other. So the atria is working on its different pattern, and the ventricles are different, are acting at a different pattern. Okay, so दोनों अपनी जोन में जो है वो चल रहे हैं. So इसका पोएम का आखिरी मिसरा क्या है? If P's and Q's don't agree, then you have a third degree. Okay, now they don't agree with each other anymore. They are independent of each other. There are more P waves. कोई पैटर्न आपको समझ में नहीं आएगा. And so that's how you know that आपको जैसे वहां पे समझ में आ रहा था कि after every 2 P wave you are going to get a drop in the QRS. But here there is no association. इसको हम AV dissociation भी कहते हैं. Okay, so now you know that यहाँ पे एट्रिया का रेट डिफरेंट होगा एंड क्यूआरएस का अपना रेट चल रहा होगा. जैसे हमने पहले एक रेट कैलकुलेट किया था ना, हार्ट रेट आर आर इंटरवल से, यहाँ पे डिफरेंट रेट होगा. पी वेव्स अपने रेट पे होंगी और क्यूआरएस अपने रेट पे होगा. सो देयर दे आर इंडिपेंडेंट ऑफ ईच अदर नाउ, एंड देयर विल बी मोर पी वेव्स. So we'll be doing that, and it is very commonly seen in a case of if the mother has is a patient of SLE, and they'll give you a background and a scenario that the mother has SLE, and the patient is the newborn who is just delivered is having a ECG of this, and they'll give you a picture of ECG, and there will be a third degree heart block. So it is basically a case of SLE. Okay. सो थर्ड डिग्री हार्ट ब्लॉक, तो थोड़ा बहुत आपको वैसे सिनेरियो से समझ में आ जाता है, एंड देन you should expect a third degree heart block in a case of maternal SLE. So yes, this again is a slide that is showing all the heart blocks. Okay, so the first में क्या हो रहा था? Just PR was getting prolonged, but at equal interval पे हो रहा था. ये भी long है, ये भी long है, ये भी long है. But in second degree Mobitz type 1 we were getting progressive prolongation of the PR interval. It was shorter, then it got longer, and then again longer, and then more longer. That there is a drop in the QRS. So drop of the QRS basically start from the Mobitz type 1. And then again in the second degree of Mobitz type 2, what are we going to get? We are going to get the constant PR interval. So there is no progressive prolongation. So this part basically helps you in the exam, that you know progressive prolongation we only get in the Venki back like Mobitz type 1. So in second degree Mobitz type 2, there will be constant PR interval until the drop in the QRS. So basically these are quite confusing when it comes in exam. So बेसिक डिफरेंस यही है कि इसमें प्रोग्रेसिव प्रोलोंगेशन हो रही है और यहाँ पे कांस्टेंट पीआर इंटरवल है अंटिल देयर इज अ ड्रॉप बीट और एक कांस्टेंट रेट पे हो रहा होता है. Exam में they don't usually give very long ECGs, but this PR interval, distance of PR interval is going to help you in the exam that whether it's Mobitz type 1 or Mobitz type 2. And the third degree is very easy to pick, which we also call as complete heart block. You can see. So T wave कहाँ है, QRS कहाँ है, there is no relationship between them anymore. Okay. So now we get to the QRS complex. Okay, so QRS complex, as in the first few slides, I show you the wave. The Q is the negative deflection, the first negative deflection on the ECG graph. And then there is a R wave. Okay, and then there is a R wave, which is the tallest, like this. So the tall part is the R wave, and then we get a negative deflection again, the S wave, and it shows us about the ventricular depolarization. So what you should know about this, that it is around 85 milliseconds in the first year of life, and it can be up to 120 milliseconds in adults, okay, like 0.12 seconds. So um, now, what is important regarding the QRS complex, that we should know that which QRS complex is wide and which one is narrow. So we'll be discussing this in upcoming slides also. So I just wanted you to memorize that in which conditions we are going to get the wide QRS, okay? Because the narrow ones are very few, and we'll like repeat them again and again. But the white QRS, there are many conditions which are asked in the exam. Then in which condition you get the white QRS complex, okay? So white QRS complex you get in the case of left bundle branch block, right bundle branch block, and in the cases of post cardiac surgery. For example, they can give you a scenario of that the patient just went through VSD closure or TOF repair, and then he's getting an ECG like this. So you have to know about the right bundle branch block. Today I did not include about the right bundle and left bundle. In the next class, I'll be talking in detail about the what are the findings that you're going to get in the right bundle branch block and the left bundle branch block. In the left bundle, basically, there were two mnemonics that we used to memorize back in MBBS days, William and Marrow. And I am expecting you guys also have heard about these terminologies. Um, so we'll talk in detail about the bundle branch blocks in detail in the next class. Okay. So yes, an incomplete right bundle branch block, that is common with ASD, WPW syndrome, and then ventricular arrhythmias, and in case that whenever there is pacemaker is attached. Okay. So these are the few conditions for the QRS complex. Now we get to the ST and T abnormalities. So ST elevation, which ST segment that we call that it is enlarged or it is elevated. So ST elevation should be less than 1 millimeter in the limb leads and less than 2 millimeter in the left precordial leads. I hope you all understand about the limb leads and the precordial leads. Precordial leads are basically 6 leads that are attached on your chest. Okay. So starting from the right to the left. So V1, V2 are mostly on the right and the interior chest, and the other V3, V4, V5, V6 are more towards the left side, covering the mostly the left part of the heart. Okay, so these are the precordial leads, and it should be less than 2 millimeter in the left precordial leads. If it is greater than 2 millimeter, then you are going to call it that it is ST elevation. And T wave inversions, we'll talk about T wave in a detail in the next slide. So T wave, they are normal in V1 and V3 in children. So ये discuss करते हैं अभी next slide में. So don't worry about that. And in which conditions you are going to get ST elevation in children? In adults, we have read in our final year a lot about the ST elevation and MI, myocardial infarction. We all have read about it. But in children, MI is not common. Okay, so you should know that which conditions are going to cause this abnormality. So in case of pericarditis, in case of myocarditis, again ischemia due to some reasons, and potassium abnormalities are going to cause ST elevation in children. Now we get to the QT interval. It is very, very important as far as AKP is concerned. You're going to get, I think, at least one scenario of QT interval. So basically, this is the formula, Bazit's formula. So QT interval divided by square root of the RR interval. So this is how we calculate the corrected QT, and it should be greater than 0.49 to become abnormal. So basically, you can say less than 0.49 is normal. Again, there is age variation that is given in pediatric guidelines as well. So you can go through the table, but I know as far as the exam is concerned, it is very difficult to memorize according to the age. So you should just know about the like I'm not telling you to memorize each and everything and each and every reading according to different ages. It is a very difficult thing. So according to the scenario and according to a rough idea that greater than 0.49 second is going to be abnormal, and you are going to get the answer uh, by a combination of scenario and a rough idea and a rough background that you have. So you're going to pick and you're going to pick the answer, hopefully, inshallah. Okay. So just for your information, I wanted to tell you that ECG guidelines interpretation is given in the pediatric guideline book. I think it's page number 131. Just go through that for once. After this presentation, I don't see a point. I think I have covered everything, but just go through that so that you know if anything's different. Okay. So now I'll be telling you about the prolonged QT interval and the short QT interval. Obviously, long QT interval is a common scenario. So just memorize all the things that are going to prolong the QT interval. Okay. So long QT syndrome, hypocalcemia, myocarditis. There are few drugs. There's a list of drugs basically which can cause long QT interval. And then there's short QT in cases of hypercalcemia, hyperthermia, and some drugs that can also cause short QT. But I want you to memorize the long one, okay? So here we can see the long QT. Who can tell me? Can you guys appreciate? So just have a look here. And I want you to go through, always go through the long lead. Whenever you are reading ECG in a hospital or anywhere in the clinic, just go through a long lead. It gives you a better idea. Okay. So you can see here that if it's greater than two big boxes, then you are going to say that it is a long QT. So one big box was 0.2 seconds, okay? So two big boxes are going to be 0.4 seconds. And we just read that greater than 0.49 will be long QT. So here you can see. So just give me a minute. From here to here, you can see it is more than 2 more than two boxes, roughly more than two boxes here also. Okay, it's pretty long. Okay, Okay, if there's anything that you are not understanding or it's difficult to, get, so just ask me so that I know where you guys are getting stuck. Okay, so these are the list of drugs. So I just picked a very cute and picture so that all of you just memorize by just reading the slide. So it starts with A, B, C, D, F, and these are the drugs that induce QT prolongation. And so there are a lot of antiarrhythmics that causes this. I just want you to memorize one or two names so that it will be sufficing for the exam. So amiodarone and antibiotics like ciprofloxacin, fluoroquinolones में ये आ जाती है, and then macrolides में there's clarithromycin. So these are going to prolong the QT interval, and antipsychotics. There's haloperidol and quetiapine, and then antidepressant TCAs are a very commonly asked, and then antiemetics like onset and nowadays they say that domperidone is also responsible for prolongation of the QT interval. And then antifungals again can cause prolonged QT interval. So they are asked in the exam. So you should know that. Okay. So there are different types of QT, long QT syndrome. Long QT1 is basically exercise triggered. Long QT2 is emotionally triggered. And long QT3 is usually sleep triggered. Most of you have known the stories that a child was sleeping or the adult was sleeping and then he didn't wake up. So scenarios like that, they tell you about these things. And sudden collapse also, and there are some syndromes like Jervell and Lange-Nielsen syndrome, which have association with the long QT. Okay, so these are most commonly, basically, long QT is associated with the cases of sudden deaths. Okay, so if a child, they give you a scenario of fainting, that the child doesn't have any problem, but suddenly he faints. So you have to see, you have to dig in deep and then get their investigations done and always rule out these conditions. Okay. So then there are syndromes, like I mentioned here. So they are inherited, and there is also deafness associated with sensory neural hearing loss associated with this QT interval. So in a scenario, if you are getting that the father is also deaf and the child is fainting, so you should also make an idea by that scenario that maybe he's talking about long QT syndrome. Okay. Okay, so now we'll discuss a little bit about the hypertrophies. Like initially we discussed about the right axis deviation and the left axis deviation. Now we are going to talk about the hypertrophies. The right ventricular hypertrophy and the left ventricular hypertrophy. For as far as pediatric ECG is concerned, right ventricular hypertrophy is a more commoner scenario than the left ventricular hypertrophy, because left ventricular hypertrophy is more common in adults. Okay, so left ventricular hypertrophy, in which leads you're going to get, like for example, for the axis I told you, just have a look at the lead 1 and lead AVF. Okay, so in this case, I want you to look at the V1. Okay, and this is the precordial lead. So just have a look. Initially, in a normal ECG, you will see that in lead V1, there is a small R wave. Okay, and वो small होते होते, और इनिशियली होता ही है कि वो पॉजिटिव और नेगेटिव डिफ्लेक्शन के दरमियान की एक कंडीशन होती है. I'll show you a normal ECG in the next class so that you can make a better idea that how does it look like in a normal ECG. So पॉजिटिव और नेगेटिव, जैसे फॉर एग्जांपल हेयर इस तरह की होती है नॉर्मली, पॉजिटिव नेगेटिव एंड स्मॉल होती है. एंड देन as you are moving towards the left side of the heart, it increases in size like this one. So in V5 and V6 in a normal ECG, usually you get the tall R waves. 2 to 3 big boxes are there. So, but in the case of right ventricular hypertrophy, you're going to get the tall V1. As you can see here, V1 is tall, which is normally not there, okay? So, what he's saying that pure R wave in V1 after the 6 months of age, okay? And 1 year old patient with right ventricular hypertrophy. So you get these tall in the V1. So always look at all the leads. For example, I told you about the the first step of the ECG that I mentioned is not like relevant for the exam point, but from the rhythm part, just go through the rhythm, regular, irregular. Then you have to go through rate. Okay, what is the rate of the ECG? You all know by now that how do you calculate the rate, whether it's the rhythm is regular or irregular. Okay, just have a look whether it's sinus rhythm or non-sinus rhythm. Okay, then you go to the axis. Axis देख लिया आपने, left है, right है, normal axis है. Then in case of right ventricular hypertrophy, you are going to get the right axis deviation. So always whenever you pick right axis deviation, just go, always look at the age. If it's neonate, then it is going to be a normal phenomena, right? But if the age is different and then you get the right axis deviation, then always look for the changes of the right ventricular hypertrophy. Always go to the lead one. Just have a look at the how tall is the R wave. If it's tall, then you can say, oh my God, this patient is having right ventricular hypertrophy. Like in case of, they can give you a scenario of TOF, and in case of VSDs, they can give you, and then ASDs. So these things can come in exam, okay? So always look at the V1 and make an idea, okay, this is tall R wave and this is right ventricular hypertrophy. See, this in V2, it's also very tall. But V5, V6 में वो small हो जाती है. So in the anterior chest leads V1 to V4, there are tall R waves. Okay. Then you get the right axis as I already told you. So right ventricular hypertrophy मिल जाए तो right axis deviation को ढूंढें, लेकिन always if you will follow the scheme in the exam, it will be very easy for you. So if you get the right axis, always look for the right ventricular hypertrophy. Again, if we go to the left ventricular hypertrophy, you're going to get the findings in the V5 and V6, because V5 and V6 are located along the left side of the chest. Okay. So they are covering the left ventricular area. Now you can see here. See how long. So usually they are around 3 to 4 big boxes. But if it is greater than that, then you can say, okay, it's left ventricular hypertrophy. Okay. So again, you get this here. Okay, now we come to the T wave abnormalities. Okay, so now this part is really interesting here as far as pediatric ECG is concerned, because I told you that there are few changes that are different, that are going to be different from the adult ECG. Okay, so in children, like T wave is always positive in the V1 in the first 7 days of life. In the first week of life, the T wave is going to be positive in the V1. Otherwise, it is negative in the AVR and the V1. Okay. So in the first 7 days, it is positive, and again after 7 years, it is positive. So you can just memorize the figure of 7. So in the first 7 days, positive in V1. After 7 years, it is going to be positive in V1. Otherwise, in a normal ECG, it is going to be negative in V1. T wave is negative in V1. Okay, and positive in V1 after the first week of life. If you are getting positive T wave in lead V1 after the first week of life, then it is always suggestive of right ventricular hypertrophy. Okay, so I think it's pretty much for today. Yeah, the time is 11:20 almost. Okay, I'm just going to just sum up, wind up this lecture here. Just memorize that tall T waves are due to the hyperkalemia and the left ventricular hypertrophy, and the flat T waves is due to the hypokalemia, hypocalcemia, hypomagnesemia, in hypothyroidism also, and in cases of inflammation in the heart like myocarditis and pericarditis, we are going to get the flat T waves. Okay, so I told you about the pediatric ECG. What are the different things? And we have discussed, I think, majority of the things we have already discussed, that there is right dominant heart presence in cases of ECG, that we get the right axis deviation and right ventricular changes like right hyperventricular hypertrophy. And you know that heart rates are usually greater in children, and especially in the neonatal age the heart rates are much higher, and then they become like they decline with the age. And again I told you about the T wave changes. T wave inversions in the right precordial lead is considered as normal, and in the first 7 days it will be positive, and again after the 7 years of age it will be positive. So and the intervals are usually shorter. When you will go through the guidelines that are given in the pediatric guideline book, so you will know that according to the age, the intervals are increasing and the heart rate is decreasing. So I think, um, do you want me to proceed with the classification of tachycardia? Because this is also an interesting topic. So if you want guys me to continue, then I'll continue. I want at least 3 to 4 votes, please. Okay. Okay, some they have mixed. ओके इस तरह करते हैं कि आपको थोड़ा सा एक ओवरव्यू देते हैं रिगार्डिंग द टैकीकार्डियाज, and I'll just quickly just go through them, and I'll not go into the detail, and we will again discuss this in the next class along with the examples. Okay, so टैकीकार्डिया का आपको ये पता होना चाहिए कि which tachycardias are common. Whenever you get the heart rate which is more than age appropriate, then what are the things that you are going to look for? Okay, so there is narrow complex tachycardia and there is wide complex tachycardia. And in the narrow complex tachycardia, the most important ones are sinus tachycardia and the supraventricular tachycardia. Sinus, as the name indicates, P wave will be preceding, QRS will be preceded by the P wave, and there will be tachycardia. यानी कि हार्ट रेट ज़्यादा होगा लेकिन हर QRS से पहले P वेव आपको मिल जाएगी. दैट विल बी नोन एज साइनस टैकीकार्डिया. और साइनस टैकीकार्डिया आपको किन चीज़ों में मिलता है? whenever you are having pain, whenever you are having a child is having fever, तो आपको पता है मेटाबॉलिक रेट बढ़ जाता है, तो हार्ट रेट बढ़ जाता है. हार्ट रेट बढ़ जाता है तो इट कैन गिव अ पिक्चर ऑफ tachycardia, but it will be preceded, QRS will be preceded by the P wave. The P wave will always be there. Again, the second important example of supraventricular tachycardia, narrow complex tachycardia, supraventricular tachycardia. It is again very, very, very high yield for exam point of view. So in supraventricular tachycardia, we are going to discuss that what are the changes that you are going to look for in supraventricular tachycardia, that whether P wave is there or not there. Okay, and what are the specific changes that are going to present here. And again in the wide complex tachycardia, QRS की बात हो रही है तो it will be greater than 120 milliseconds. So in cases of VT, ventricular tachycardia, we are going to get the wide complex tachycardia. So can you appreciate these mountains, these little पहाड़ियाँ? So ये पहाड़ियाँ आपको नजर आएंगी whenever you get to see these in exam. ज़्यादा उसमें घुसने की ज़रूरत भी नहीं है कि 120 मिलीसेकंड्स है नहीं है, कैलकुलेट करें क्या करें. जस्ट हैव एन आइडिया. इतनी आप इसको देखें, लाइक गो just Google it, all the pictures on the Google or in your books. Just go through ventricular tachycardia pictures. So you'll be like, it will be very easily picked in exam. So you can see there's wide, basically, if medically you want to say what are the findings here, that there is a wide complex tachycardia, और आसानी से आप इसको कहें तो ये छोटी छोटी पहाड़ियां आपको नजर आएंगी, तो यू कैन से दिस इज अ केस ऑफ वी टैक, ओके, क्योंकि इसको दूसरे कंडीशन से कंपेयर करना बड़ा आसान हो जाएगा. सो अगेन यू कैन सी ये पहाड़ियां आपको नजर आ रही हैं, ओके, these little mountains. Now we come to the sinus tachycardia and the now we come to the examples of the narrow complex tachycardia. अब यहाँ पे आपको नजर आ रहा है, and you can see here, यहाँ पे आपको हार्ट रेट कितना है, कैन एनीबडी टेल? रेट तो रिदम तो आपको नजर आ रहा है, बोथ हैव रेगुलर रिदम्स, राइट, बट हाउ मच इज द हार्ट रेट? लेट्स गो टू द चैट बॉक्स. How to what will be the heart rate in it, and how to comment on the heart rate in VT? Okay, just understand that nobody is going to ask you for the heart rate in VT. Okay, VT is always asked for the treatment from the exam point of view. Okay, and again, if you like really want to know the answer, so just you have to calculate the R, and again follow the same formula and you'll get the heart rate. Obviously, it is going to be greater because these are examples of tachycardias. Above 150, very nice. So I have slides on supraventricular tachycardia in detail, that at what heart rate you are going to label it that it is supraventricular tachycardia, and there will be no P wave. Like I mentioned, in sinus tachycardia you are going to have a P wave. Like see, you have a P wave, P wave, P wave, P wave. Okay, but in case of SVT there will be no P wave, and heart rate will be more greater than the sinus tachycardia. So Um, yes, okay. So, what happens? Both are very common in children. Okay. So, it is gradual in onset, it is sudden deterioration. अचानक से बच्चा इरिटेबल हो जाएगा, ईआर में प्रेजेंट करेगा आपके पास. इन साइनस टैकिकार्डिया ही मस्ट बी रनिंग सम काइंड ऑफ इलनेस, जिसकी वजह से उसका साइनस टैकी में वो जाएगा. कोई इन्फेक्शन चल रहा होगा पहले से, या कोई डिजीज होगी, या वट एवर, कोई ऑन गोइंग इलनेस इसमें आपको जरूर मिलेगी. देन अगेन यू विल हैव पी वेव, you will have absent P wave here. The heart rate will be less than 200. And in SVT, I want you to memorize this figure, that in infants it will be greater than 220 beats per minute, and in children it will be greater than 180 beats per minute. So again, if whenever you are getting a tachycardia, for example, the child comes in ER and you are attaching a cardiac monitor on a child, and you are getting, oh my God, he's having a heart rate more than his age, then what are you going to see? Always look for P wave. If P wave is there, then you don't have to worry, because it's some kind of other problem going on, like infection or anything which is causing, or the fever or the pain. And if you manage that condition, the patient will be having normal heart rate. Okay, but in case of SVT, the management is totally different. So if you don't appreciate any kind of P wave in a tachycardic patient, then always involve your consultant, and always go for the emergency management that is required for the supraventricular tachycardia. Okay. So here in the sinus tachycardia, you can see narrow, here you can see wide, and then regular rhythm. Rhythms are regular in both. And then it's less dangerous, and I told you that it is a life-threatening emergency condition. Okay. And then there is another way to check by rhythm regularity, regular tachycardias and irregular tachycardias. So these are the examples of the regular tachycardia that I mentioned. Sinus tachy, SVT and VT, there are the regular tachycardias. Okay. And in the irregular tachycardias, AFib, which I'll be discussing in the next class, hopefully, inshallah. So you'll be clear about that. So this is, I think we should, and I think I'm going to end this session here, and we'll be discussing further in the next class. about the WPW syndrome, and I'll give you scenarios regarding the atrioventricular blocks. And then there are certain conditions like ASD, VSD. What are the changes that you're going to find? Some past recall scenarios, some exam scenarios, so that it will be easy for you to pick in the exam and whenever you're preparing from the past recalls. So if there is any question so far, if anything that is unclear, feel free to ask any question. Okay. Yes, Dr. Babar. Inshallah, from Monday onwards, I'm going to plan these sessions in the morning. So we'll be fresh and more mentally available, hopefully, inshallah. Okay, you're most welcome. So no questions so far. I think you have understood everything. I'm going to bring difficult ECG for you guys so that I know that my presentation was helpful or not. Okay. So thank you so much for joining, and hopefully see you all in the next class. Okay. Take care. Have a good sleep. Allah Hafiz.